great lunch. For those who were not present in the morning session, I'm Rubana Islam again, and we are about to commence the second plenary of the day titled Governance for Urban Health Promises Way Forward. We are pleased to have as chair Mr. D.K. Nath, Consultant, Urban Health, Bangladesh, President Mission, Asian Development Bank, and co-chair Zuena Aziz, Additional Secretary, Ministry of LGRT and Police. I'd like our honorable chairs to please come and take the seat on the podium. And we have Mr. Anthony Cole, Urban Health Advisor, USA, as our speaker, and Dr. Hossein Zillur Rahman, former advisor to the taxpayer government, economist and sociologist, and Mr. Kishore Kumar Singh, from Poverty Reduction Specialist from UPR. Please come and take your seats on stage. Kishore Kumar Singh, Dr. Anthony Cole, his primary focus is supporting USAID contributions in improving and expanding health activities among the urban poor and integrating field experiences from those efforts into agency-backed best practices. Please welcome Dr. Anthony Cole as our first speaker.
Good afternoon, everybody, distinguished presenter, distinguished participants, ladies and gentlemen. We are going to have our evening afternoon session after the rounds, and as you know, this is the governance for urban health promising way forward. With me, you know almost everybody, my colleague, co-chair, Zuena, she is the Additional Secretary, Minister of Local Government, Rural Development and Cooperative. Then, Mr. Anthony Paul will speak about the global governance on urban health. Then, you know, the popular face and our friend, Mr. Dr. Hossein Zillur Rahman, he will speak about the political policy context of urban health in Bangladesh, one of the most important areas, and promoting community participation and linking, improving urban health governance and reducing urban poverty. Kishore Kumar Singh, and he is working with the International Poverty Reduction and especially UPR. And then we will join our video conference with Dr. Selina Haya Ivy. She is the mayor of the Narayanganj City Corporation. So with this, in fact, this is the session, one of the most important sessions, I must say, governance of the urban health. What are the intervention, what are the policy, dimension, strategy we are taking, everything lies on the governance issue. And here is the critical issue which we take today. In fact, when we speak of the governance, then we speak about the manner in which power is exercised in the management of the country's economic and social resources of the development, where lies accountability, predictability, participation, and transparency. So, with these few opening remarks, I will now invite our first presenter, Mr. Anthony Cole. He will speak about his experience on the global governance of the urban health. Mr. Anthony, please.
Thank you, Mr. Chairman, for the welcome. I'm sorry that I'm not yet a famous face or popular face in Bangladesh, but hopefully if I continue to return and work with you all, maybe that will happen someday. I want to be fairly brief in my remarks and hopefully a little bit controversial because I think these sorts of forums lend themselves to discussion rather than lecturing. And I'm certainly not a lecturer on this topic, although I do make many presentations on urban health to students and others. But I'm still a student myself because the field of urban health is a very young one, a fairly ill-defined one. And I think it's really part of my job is to try to learn. And that's why the title that I used was a little bit different from your program. It's not a global governance. I don't think we should necessarily have global governance. It's actually the opposite point of my key governance point here, but rather a global perspective. From the great opportunity that I have to work in many countries around the world and learn from different countries' experiences addressing the health of their urban population. So to start off, I'm not going to give you statistics on the urban health problem. One of the more published authors out of the UK on this subject actually made a pledge never to make a presentation like that again, because there are too many presentations on the problem and way too few presentations on what the solution sets are, especially in developing countries. So how do we move beyond it's a problem? And I just wanted to try to give you my shorthanded answer to these three questions. Where do we focus? What is sort of the, where do we go? We know that urban areas are a geographically defined space. And I think that anybody that works in urban programming understands that within that geography, it's very important to understand the complexities of it. So how do we take those understandings and apply it to health concerns? And then what are the appropriate tools? What are sort of the solution set that, in very broad terms, need to be applied? And then understanding where we need to focus and the sort of tools that need to be applied, what are the governance implications of that? My first controversial statement is the answer to this question is really no, not really, not necessarily. And I think for a lot of people in the room that have programs that are described as slum-orientated urban healthcare delivery, maybe you're going, what? This is, I guess I got the year wrong. It's actually 2006. Dr. was presenting some of this work this morning that was partly funded by UC Bangladesh. I use this picture all the time in talking to students about urban health concerns because I think the misconception in many people's minds about slums are the big slums, the famous slums that people know about, the Kiberas in Nairobi, the big agglomerations of the ones that really stand out from aerial photos. But the reality of urban poverty in most cities is that it's much more complex than that, and oftentimes very dispersed. And if you look at the sort of green outline sections here, this is a detail of just one ward in Pune. And you see these points of urban poverty concentration throughout the city. If you were to target implementing an NGO clinic in each of those spots, you start having a lot of clinics to have to establish. And the question is that really the right approach? Based on some multi-country analysis of the DHS, where we were looking at poverty and local definitions of slums, that work also to me suggests that it's not always true, although maybe it's sometimes a good shorthand to talk about the equality between health vulnerable populations in urban areas and slum spaces, particularly when you get different areas of health concern. For example, in various countries, this doesn't necessarily, the concerns around HIV/AIDS, especially in prevention and reaching of target populations, it doesn't really follow a slum geography necessarily. So tuberculosis, maybe to a degree, certainly problems associated with viral disease, as the slum definition is largely an environmental definition, there's a strong correlation. But it's not a perfect correlation, and that's my point. In particular, depending on different countries, slums definitely do not equal poverty. There are rich people living in slums, there are poor people living outside the slums. Urban geography is much more complex than simply equating poverty with the type of housing that people are currently using. So what, again, this suggests to me is that mapping and understanding the geography of health concerns always needs to be done. It's always different in every city, and the shorthand of the slum definition is not always the appropriate one to use, depending on the health disease burden that you're trying to address. And as a result, interventions have to be tailored at that sort of local level. So, the question for the first one is, it depends. Oh, by the way, that child was not sleeping in the slum. The child was sleeping in the middle of a business district. So, what are the appropriate tools? USA funded a survey among residents of urban populations and providers in those cities, in India, several cities in India and several cities in Manila. And to me, the survey was finished shortly after I joined USAID. So it was one of the first sort of raw materials coming in from the field that sort of informed my thinking as I took on the role of urban health advisor. And I present this in two perspectives. The common perspective, which both poor people and providers agree, is that private sector providers are very important. And I mean, this is not startling for anybody that understands how health service delivery works in urban areas, almost everywhere in the world. But it is startling to your typical Ministry of Health official, whose focus is on rural public health services. And in that context, the public services are almost the sole source of service provision. And that's their perspective on the world. So understanding that the private sector is currently very important can be very useful to emphasize when you're talking to folks that are educated in rural health service delivery. And then the corollary to that is that the cash barriers to service are extremely important. So the cost of service is key in this situation. Where the service providers and sort of the urban poor disagree is around more subtle things. And it suggests a general lack of good communication and linkage between health service providers in many city contexts and the urban poor in particular. This may not be surprising in that, well, if you're a private sector doctor or one that is working in the public sector and making a lot of money on the side, the urban poor aren't necessarily a great interest to you. They're difficult patients, they don't pay on time. But more specifically, there are many quotes about, well, they don't even understand simple instructions about how to take medicines. You know, they're illiterate, they're difficult to work with. And there's a matching sort of perspective from the urban poor that the health service providers that they interact with are insensitive to their needs. They don't open at the right time with their government providers. They just are out of sync with their needs. And there's also this view that the poor are some part of this mess of disorganized social reality. And I think there was even some mention of that this morning about some of our speakers. And I think the general recognition for anybody that works in poor urban poor populations is that that's not true at all. That there's actually a lot of structure and a lot of formality to informal economies and informal arrangements that people depend on in poor urban areas. So the answer to that question seems to appear that we need to think about how to leverage the private sector in some way. If it's co-opting or regulating those that are in the profit world, or utilizing NGO private sector deliverers in a subsidized way. And we need to focus on developing proactive linkages between the urban core and providers. It can't be just waiting in the clinic for them to show up. It can't be not trying to understand what the immigrant's local language is, understanding exactly the times that people want to use a clinic, not just telling them what time it's open. It's being sensitive to the needs of a particular type of population. So, if you buy my conclusions or my answers to these questions, what are the sort of simple governance implications? And I'll finish on this. Well, we heard this morning about the sort of the WHO perspective that came together largely in Europe, but certainly pursued very strongly in Latin America and to a lesser degree in Asia under the Healthy Cities program. And the focus, to me, you know, I think generally the focus of the approach that WHO chose was, of course, very appropriate for these countries, but maybe not so appropriate for the emerging economies. And I think that's been a core part of the criticism, in a way, that it's not sort of globally applicable. But I pick out of this approach a particular key message. The problems might be different. The lifestyles and thus the sort of relationship to urban design, having places where you can go bicycling and walking and have more physical activity. I think we saw a poster on that suggestion for Bangladesh. But to get those things done, you need municipal, local level leadership. National governments can't mandate bike lanes. They can't negotiate with neighborhoods about the locations of improved services. It has to be done at the local level. Another perspective, but coming off with actually a similar message, is work that we began supporting in India back in 2002. The motivation there was more of a typical sort of slum upgrading motivation, where sanitation was the sort of key organizing concern. So it was an environmental health focus initially, but we evolved that into more of a broader maternal and child health focus. And it has led recently to the adoption of a new national program, Urban Health Mission in India. The nature of the program, since India is much more centralized, at least in the financial resources available for health, and the sort of vision of what the problem was coming from the national level, the national government has sort of led. But the recognition is to get anything really done and tailored to the individual problems of very wide diversity of cities in India, you have to engage state governments and the municipal level in a very creative way. And it has to be not one size fits all. You have to help them plan and tailor the approaches to their particular needs. Again, the problems are probably going to be somewhat different that you're trying to solve. You'll probably be still focusing on sanitation and water improvements, basic maternal and child health service delivery. But the bottom line message on governance is that local government, municipal leadership, is extremely important to find appropriate solutions. But where that's weak, as in the case of India, you need national level leadership. If it's in the form of resources, of money, or resources of intellectual capital. The challenge for the municipal level and national level leadership is in trying to find governance situations where health and non-health departmental actors come together. I mean, that's true from the WHO model of talking about urban design. Ministries of health aren't responsible for urban design, or local health departments are responsible for urban design. Others are in the bureaucracies. But to influence them, the ministries of health or the departments of health have to have an influence on that. They have to be pushing for things. They have to understand the language of urban design. The same would be true in India dealing with water and sanitation issues. Those departments have to be able to talk to each other and have the same perspective and priorities at some point to make it come together. And I just want to note, just in the breakout session that I attended this morning, which was on water supply and sanitation sort of issues, that was my question for the speakers. We're really coming from the water sanitation world, not from the health world. And at least in Bangladesh, there seems to be a pretty big disconnect between those two worlds. And if they're going to come together, you have to develop a serious dialogue, a dialogue that's informed by the sense of trying to have mutual action. And that can be oftentimes very difficult to build up. But it builds up easiest at the local level. Getting two ministers to talk to each other, very, very difficult. Getting a mayor to yell at the department heads of two departments that he controls, in most countries that's a little bit easier to do. And finally, we need new capacities within the health world to be able to leverage the private sector and adopt approaches to the particular characteristics of vulnerable urban populations. That's the new skill set that has to be evolved in the governance portion of public health in any country. But as I said, although I think the Dutch maybe have a lot of answers for a lot of things when it comes to urban health, well, I don't know if you could apply all of those solutions to the context of Bangladesh today necessarily. The world continues to change. There's different opportunities to deal with a more connected world. And again, urban health is in a very early stage of understanding what the solution sets are, particularly for developing countries today. The most cost-effective ones, the most effective ones in terms of health outcomes. And USAID is, at least from my side, is very committed to trying to make this exchange of understanding continue to grow so we get better results. Thank you.
Thank you, Mr. Antonio, for your excellent presentation. Those who have got any question, please take it to note for you. After all the presentation, we will go for the discussion and we will invite the question. Now I will request Dr. Hussain Dilur Rahman, provided by the Government of an economist and a socialist, and he will speak about the political and policy context of urban health in Bangladesh.
Thank you, Mr. Chair, and thanks to the organizers for this opportunity. I am a non-health professional, so my job today is to basically provide a reality check from a political and policy standpoint on how the wealth of good ideas emerging from the health sector, what chances they have of traveling the distance in the policy and political world. So it's a reality check job that I have planned for myself here. I have just 2 slides actually. It's a very small presentation. First of all, I talked about certain perspective issues. We need to get the perspectives right if suggestions are to travel the distance. And I think the previous speaker has already touched on a few of them, but let me sharpen them for the Bangladesh context. 4 perspective issues that I want to sharpen. I think the first one is already alluded to, that urban health is an issue of the urban agenda. Urban agenda itself is on the margins of the policy discourse in Bangladesh. So getting urban health discourse off the ground also requires us to scale up the urban agenda itself. And I know that in the morning session we had a session on healthy cities. I think it's absolutely important that the narrowly health discourse will not find too many listeners in the policy world unless it is also tied in with the urban discourse itself. So we have the challenge of a coalition whereby the urban sort of advocates are also simultaneously talking with each other. That's a key issue, unless we get there off the ground. And there is, the reason it's at the margin, the urban, the policy interest on the urban is at the margin, is not because of a knowledge gap, that people, the policymakers are not aware of this issue. There is a genuine dilemma within the policy mind. The dilemma is that if you attend too much to these urban issues, more people will come here. This is a false perception, but it's a dominant perception. And one has to somehow dislodge that perception effectively if you want to get the whole thing going. UNDP actually organized and the local government ministry organized a massive conference last year, the Bangladesh Urban Forum. The chief guest of that forum was the leader president of the country. And I saw the irony in the whole situation when Daily Star headlined the coverage of that huge effort at upscaling urban interests by paraphrasing the president's core message. We have to concentrate on the villages. This was the chief guest sort of understanding the problem in that way, that if you can somehow improve the villages, more people won't come to urban centers. This is absolutely, it flies against the face of empirics, but as a perception, it is so deep-rooted, we have to strategize how to, try and get over that. So that's one perspective issue we need to keep in mind. The second one is that Bangladesh, yesterday we saw the Lancet launching ceremony, so much of this huge progress made on the health sector, on many indicators, etc. Many of them actually are rural progress. Many of those indicators are rural progress. Now, rural poverty and urban poverty, one might think that they are basically same things but in different spaces. But I think the research, the arguments, the policy discourse on this is not yet over. In fact, it hasn't started seriously enough on the urban issue. I think the previous speaker just posed the question at the very beginning, should urban poverty be equated only with the slums? That's already is mentioning a little of how these issues are to be understood. And I think yesterday also I made this point, but I think for strategic reason I want to highlight this statistic, that in the rural areas, when all these government interventions to improve their situation produces results, we see that the social and economic indicators of a poor household move parallel, meaning if their income position improves, their health, their education position also improves in the rural areas. In the urban areas, we see a divergence. Between 2005 and 2010, extreme poverty in urban Bangladesh was halved, which means that massive progress on the economic indicators. Social indicators, particularly literacy and some of the health indicators, it's stagnated. So there is a dramatic contrast in terms of what is rural poverty and what is urban poverty. It has not been taken on board sufficiently yet in terms of the policy understanding. For example, just think of in the rural area, when you think of sanitation solution, it's essentially individualistic solutions. Land is not such a great concern in the rural areas. In the urban context, land is of the highest concern. Therefore, a paradigm shift which is necessary in terms of shared facilities, which is completely different from the rural areas. These are the thinking frontiers we have to really take on board if we need to grapple with this issue of urban health. My center, PPRC, is partnering with the Bangladesh Bureau of Statistics to develop an urban database. We have completed the survey on Dhaka city. Hopefully, early next year, we will be launching the Dhaka City Report, which is the first time a comprehensive representative survey has been done, where hopefully some of the urban poverty characteristics will be analyzed in detail. The third issue is, as a perspective issue, I again mentioned, is are there additionalities in the urban health agenda as distinct from the rural health agenda? For example, drugs. This is not in the rural health agenda so much. Workplace safety. This is not so much in the rural health agenda. There are additionalities which have to be explored, which also has to be brought within the health agenda. because they have an impact on the whole issue of health, which in the rural context is not so prominent. So these also need to be taken on board, and if the discussion starts, we can pinpoint which are the ones to be taken on board. Fourth issue, as I mentioned in the very beginning, we are starting at a point when there is low policy interest. This fantastic progress that we heard in the Lancet launch yesterday also comes with the knowledge that the health sector budget was reduced in the last budget, which is a message that the policy actors really are not on board in terms of the priority to be given to the health sector. The ex-health minister was there yesterday. He mentioned that he couldn't win the argument with the finance minister of at least preserving the level of budget that they had before. So it's a low policy interest in which